Hello and welcome to our comprehensive guide on anaphylaxis, a severe and potentially life-threatening allergic reaction that requires immediate treatment. In this video, we'll cover the causes, symptoms, and signs of anaphylaxis, along with how to manage it effectively. We'll also tackle some common USMLE-style questions to help you understand this critical topic better. Question 1. A 30-year-old woman develops acute difficulty in breathing, facial swelling, and a rash shortly after being stung by a bee. What is the first-line treatment for this condition? Answer. The first-line treatment for anaphylaxis is epinephrine. Administer epinephrine intramuscularly as soon as possible, ideally in the mid-anterolateral thigh. For adults, the dose is 0.3 to 0.5 milliliters of a 1:1000 solution, 300 to 500 micrograms. This can be repeated every 10 minutes if necessary while monitoring blood pressure and pulse. Explanation. Epinephrine acts rapidly to counteract the severe symptoms of anaphylaxis, such as airway constriction and cardiovascular instability. Prompt administration is crucial for reversing these symptoms effectively. Question 2. A 6-year-old child presents with a history of severe allergic reactions to peanuts. Following exposure, the child develops hives, wheezing, and has difficulty breathing. What dose of intramuscular epinephrine is recommended? Answer. For children, the recommended dose of intramuscular epinephrine is 0.3 milliliters of a 1:1000 solution, 300 micrograms. This dose can be repeated every 10 minutes if needed. Explanation. The dose of epinephrine is adjusted for children to ensure safety and effectiveness. Immediate administration is critical in reversing the symptoms of anaphylaxis. Question 3. What investigation is used to confirm anaphylaxis and identify the specific allergen involved? Answer. Skin prick tests and serum-specific IgE tests are used to identify specific allergens. Additionally, a full blood count, FBC, can be performed to check for eosinophilia, which may support the diagnosis of anaphylaxis. Explanation. Skin prick tests provide immediate results for identifying common allergens, while serum-specific IgE tests measure the level of IgE antibodies to specific allergens, helping pinpoint the cause of the allergic reaction. Question 4. A patient with anaphylaxis shows severe hypotension and tachycardia. What is the most appropriate fluid management strategy? Answer. Normal saline 0.9% should be administered intravenously. The typical volume ranges from 1 to 4 liters, depending on the patient's clinical response and blood pressure. Explanation. Fluid resuscitation helps restore blood volume and improve blood pressure in the setting of severe hypotension. The amount and rate of infusion are adjusted based on ongoing assessment of the patient's vital signs. Question 5. A patient with anaphylaxis is experiencing severe airway obstruction. What nebulized medication should be used? Answer. Salbutamol should be administered nebulized. For adults, the dose is 5 mg every 4 to 6 hours until the obstruction is resolved. For children, the dose is 2.5 mg every 4 to 6 hours until resolved. Explanation. Salbutamol is a bronchodilator that helps relieve airway constriction and improve breathing. It is effective in treating the bronchospasm associated with anaphylaxis. Question 6. A patient with anaphylaxis has been administered epinephrine but continues to experience symptoms. What additional medication might be given to manage late-phase allergic reactions? Answer. Hydrocortisone is used to manage late-phase allergic reactions. For adults, the dose is 100 to 200 mg intravenously every 6 to 8 hours. For children, it is 2 mg per kilogram every 6 hours for up to 4 doses, not exceeding 250 mg per day. Explanation. Hydrocortisone helps reduce inflammation and prevent the recurrence of allergic symptoms. It complements the effects of epinephrine and is important for prolonged management of anaphylaxis. Question 7. A 5-year-old child with anaphylaxis requires antihistamine treatment. What is the appropriate dose of chlorpheniramine for this child? Answer. For children aged 6 months to 6 years, the dose of chlorpheniramine is 2.5 mg every 6 hours, not exceeding 10 mg per day. Explanation. Chlorpheniramine is an antihistamine that helps reduce symptoms such as hives and itching. The dosage is adjusted based on age and weight to ensure effectiveness while minimizing side effects. Question 8. A patient with anaphylaxis exhibits facial swelling and cyanosis but is stable otherwise. What additional medication might be necessary to manage severe symptoms? Answer. Aminophylline may be administered intravenously for severe airway obstruction. For adults, the dose is 250 mg over 20 minutes, followed by a continuous infusion at 0.5 mg per kilogram per hour if necessary. For children, the dose is 3 to 5 mg per kilogram over 20 minutes, followed by infusion in 500 ml of sodium chloride 0.9% every 4 to 6 hours for up to 24 hours. Explanation. Aminophylline helps manage severe bronchospasm and respiratory distress. It is used in severe cases of anaphylaxis alongside other treatments and is adjusted based on patient response. Question 9. What role does promethazine hydrochloride play in the management of anaphylaxis, and what is the recommended dosing for an adult? Answer. Promethazine hydrochloride is an antihistamine used to manage symptoms of anaphylaxis such as itching and rash. For adults, the dose is 25 mg intramuscularly, with the possibility of repeating after 2 hours if needed, then every 12 hours for up to 24 hours. Explanation. Promethazine provides symptomatic relief and complements the action of epinephrine. It is used for managing symptoms but should not replace epinephrine, which remains the primary treatment for anaphylaxis. Question 10. A patient with anaphylaxis exhibits severe hypotension. What additional treatment might be necessary to stabilize the patient? Answer. In cases of severe hypotension, normal saline 0.9% for should be administered. The volume ranges from 1 to 4 liters, depending on clinical assessment. Explanation. Normal saline helps increase blood volume and stabilize blood pressure. It is an essential component of fluid resuscitation in managing severe hypotension during anaphylaxis. Overview. Anaphylaxis is a serious allergic reaction that can escalate quickly, often within minutes of exposure to an allergen. It can be triggered by various factors, including insect stings, certain medications, vaccines, anti-sera, intravenous contrast media, and certain foods like seafood and nuts. Symptoms of anaphylaxis include severe itching, a urticarial rash, facial and perioral swelling, difficulty breathing, wheezing, collapse, and syncope. Key signs to look out for are angioedema, severe difficulty in breathing, bronchospasm with wheezing, tachycardia, hypotension, cold clammy extremities, facial edema, urticaria, and cyanosis. To diagnose anaphylaxis and identify the specific allergen, investigations such as a full blood count, FBC, skin prick tests, and serum-specific IgE tests are used. The primary objectives in treating anaphylaxis are to secure the airway, breathing, and circulation, reverse the symptoms, remove the offending cause if possible, and correct any abnormal vital signs promptly. Non-pharmacological treatment involves avoiding the allergen and performing resuscitation if needed. Pharmacological treatments include oxygen, administered by nasal prongs, 2 to 6 L/min, face mask, 4 to 8 L/min, or non-rebreather mask, 10 to 15 L/min. Epinephrine, adrenaline, IM, 0.3 to 0.5 ml of 1:1000 solution for adults and 0.3 ml for children. Hydrocortisone, 100 to 200 mg every 6 to 8 hours for adults, 2 mg/kg every 6 hours for children. Prednisolone, oral, 40 mg daily for adults, 2 mg/kg daily for children. Promethazine hydrochloride, IM, 25 mg for adults, with dosing adjustments for children. Chlorpheniramine, IM, dosing varies by age. For severe airway obstruction, salbutamol, nebulized, and aminophylline, 4, are used. For severe hypotension, normal saline 0.9% 4 is administered. If symptoms persist after initial treatment, referral to a district or regional hospital is necessary. An acute allergic reaction, or anaphylaxis, is a life-threatening condition that can develop rapidly, typically within minutes of exposure to an allergen. It is critical to treat anaphylaxis promptly to reverse the symptoms effectively. Individuals at risk should be informed about avoidance measures and may be trained in the use of an epinephrine, adrenaline, pen. Causes: bee or other insect stings. Drugs, e.g., penicillins, sulfonamides. Vaccines: anti-sera, e.g., snake serum, anti-tetanus serum. Intravenous contrast media. Foods such as seafood, ground nuts, fruits, etc. Symptoms: severe itching, urticarial rash, facial and perioral swelling, difficulty in breathing, wheeze, collapse, syncope. Signs: angioedema, difficulty in breathing, bronchospasm with wheeze, tachycardia, hypotension, cold clammy extremities, facial edema, urticaria, cyanosis. Investigations: full blood count, FBC, to check for eosinophilia. Skin prick test for specific allergens. Serum-specific IgE. Treatment objectives: secure airways, breathing, and circulation. Reverse symptoms: remove the offending cause if possible. Rapidly intervene and correct abnormal vital signs. Non-pharmacological treatment: avoid the allergen. Resuscitation. Pharmacological treatment: acute anaphylactic reaction. First-line treatment: oxygen. Binasal prongs, 2 to 6 L/min. Or face mask, 4 to 8 L/min. Or non-rebreather mask, 10 to 15 L/min. Adrenaline, epinephrine, IM. Adults, 0.3 to 0.5 ml of 1:1000 solution, i.e., 300 to 500 micrograms, repeated every 10 minutes if necessary while monitoring blood pressure and pulse. Children, 0.3 ml of 1:1000 solution, i.e., 300 micrograms, repeated as for adults. Hydrocortisone, 4. Adults, 100 to 200 milligrams every 6 to 8 hours to control any late allergic reaction that may occur. Children, 2 mg/kg every 6 hours for 4 doses, not to exceed 250 mg/day. Prednisolone, oral. Adults, 40 mg daily for 14 days, taper off. Children, 2 mg/kg daily for 14 days, taper off. Promethazine hydrochloride, IM. Adults, 25 mg, repeat after 2 hours if necessary, then every 12 hours for 24 hours. Children, 2 years 12 years, 6.25 to 12.5 mg every 8 to 12 hours for 24 hours. 2 years, not recommended. Chlorpheniramine, IM. Adults, 5 to 10 mg every 6 hours, maximum of 40 mg daily. Children, 6 to 12 years, 5 mg up to a maximum of 4 doses in 24 hours. 6 months 6 years, 2.5 mg. 6 months, 250 micrograms/kg, maximum 1.5 mg. Acute anaphylactic reaction with severe airway obstruction. Salbutamol, nebulized. Adults, 5 mg every 4 to 6 hours until resolved. Children, 2.5 mg every 4 to 6 hours until resolved. Aminophylline, 4. Adults, 250 mg over 20 minutes, then continuous infusion by perfuser at 0.5 mg/kg/hour for 24 hours if necessary. Children, 3-5 mg/kg over 20 minutes as a slow bolus injection or by infusion in 500 ml sodium chloride 0.9%, 4, every 4 to 6 hours for 24 hours. Acute anaphylactic reaction with severe hypotension. Normal saline, 0.9%, 4. 1 to 4 L, rate determined by clinical assessment. Referral criteria. Refer to a district or regional hospital if symptoms of anaphylaxis persist after stabilizing the patient and administering initial treatment. Thank you for watching. If you have any questions or need further clarification on any topic, please leave a comment below. Don't forget to like and subscribe for more educational content.